Assalamualaikum warahmatullahi wabarakatuh. My name is Daniel Salis with a few of my other members, which is Muhammad Hafiz, Nur Azrin, and Amir Faiz. We will be presenting a paper called The Active Woman Over 50, Promoting Physical Activity in Women Over 50 at RCT. Moving forward to the clinical conditions and the problem, as we all know, the clinical stage of women over 50 years old is characterized by the confluence of the lifestyle and the physiological obstacles. First of all, the biologically, menopause triggers the sharp drop of estrogen, which accelerates the muscle loss, causing the bone density to reduce and increase joint pain from the osteoarthritis. Now, this places them into the false track towards the sarcopenia, frailty, and high risk of fall. Moving forward, metabolically, a sedentary lifestyle at this stage will spike their risk of cardiovascular disease and type 2 diabetes. However, the clinical issue in this situation rather than more physical, these women constitute the backbones of the sandwich generation. As we know, they are all extreme and time constrained, balancing their demands of their career and taking care of their aging parents and their grandchildren. In addition, to treat their tight joints, our job as a physiotherapist is more to addressing the complicated lifestyle relating to and to stop chronic disability before it started to begin or get worsened. Now, the purpose of the study was actually to evaluate whether a low dose, a highly scalable behavior change program could successfully increase the physical activity in women over 50 years old. Specifically, the research sets out to determine if the minimal contact interventions could effectively drive participants to reach the key health milestones, namely hitting around 10,000 steps a day and achieve 150 to 300 minutes of weekly moderate to vigorous exercises. Now, ultimately, the purpose was to set a cost-effective public health model that used everyday technology to overcome a complex lifestyle barrier, to prove we don't need expensive, resource-heavy clinical interventions to create a lasting physical habits among these 50 years old and above women. Looking at the clinical question picker, P stands for population, which is women in the community who work at the university and the health services that is 50 years old and older. Now, the intervention is basically to use a low-dose behavior change program, consists of the educational information sessions, providing the physical activity tracker, and regular motivations email. C is a comparison between a wait-listed group receiving extended and a delayed care at the physiotherapy and rehabilitations. And the outcome consists of two, which is the first outcome saying about the proportions of participants achieve more than 10,000 steps a day, and the secondary outcome is a daily steps, a self-reported physical activity, and the proportions of individuals accumulating more than 150 to 300 minutes per week of moderate to vigorous physical activity. Now, the relevance of this research paper to a physiotherapy practice is, first of all, to change the behavioral insight. Now, the study explores the practical habit formation techniques such as goal setting and wearable technologies integrations, rather than just recommending exercises regime, assisting physiotherapists in addressing the indicates, physical and time management challenges specific to this kind of population, which is the midlife women. The second one is more to a preventive measure, and the long-term clinical starts at the age related to sarcopenia, musculoskeletal, joint deterioration, and balance deficit. The physiotherapists who currently treat in the future are directly mitigated by successfully increasing the vigorous and moderate activity with this particular demographic. This research paper also supports the evidence-based exercises prescriptions, because according to the study, even though not every participant reach 10,000 steps per day, that intense exercise is still recommended. Therefore, instead of achieving 10,000 steps a day, based on the patient's lifestyle and limitations, physiotherapy can prescribe more practical and customized exercise regime for them.
Pedro scale assessment. So Pedro scale assessment, what we want to know actually is the scale 1 to 3, which evaluate the quality of the clinical trials. There's more index on the physiotherapy evidence database Pedro, but is currently being used more frequently to evaluate clinical trials that are part of the systematic reviews in the field of physiotherapy. So there's 11 elements. So we focus for the next slide. Okay, so this is 11 Pedro items. So for the first one, I want to explain. So eligibility criteria specified. This is reported. So what is reported? Justification that we can conclude is they have inclusion criteria and exclusion criteria. Second, random allocation. So it's reported. Participants were randomly specified to specific groups. 3, concealed allocations, not reported. So there's no described method of allocation. 4, baseline compatibility. So it is reported, actually it's a group was similar at the baseline characteristics. 5, binding of subjects. There's a not done. Intervention was acknowledged by participants. Binding of therapists, they also not done. Therapists delivering treatment were aware of group allocations. 7, binding of SSS, there's an reported. So outcome SSS were blinded to treatment allocations. 8, adequate follow-up. So there's a, in bracket, more than 85% is reported. So more than 85% of participants is follow-up. 9, intention to treat analysis, there's a reported. So participants were analyzed in their assigned groups. 10, between group statistical comparisons, there's a reported. It presents a statistical comparison between groups. And the last one is point estimates and variability reported. So means confidence intervals and standard deviation were reported. Methodological criteria based on the Pedro. So we want to discuss a few of points. The first is using randomizations. So it's using the computer generated approach, then they split into 2 intervention groups and also control groups at the random. So what is the impact of the bias? So the first point is lessen bias in selections. Second, ensure that both groups are initially comparable. And then impact of the confidence. Actually, it's a boost ensuring that any variation in outcomes are due to the intervention and not other causes. Second, counseling allocations. So the randomization schedule was created by a separate researcher and group assignment was kept by secrets. So what is the impact of the bias? Prevent researcher from controlling the groups. And then impact of the self-confidence actually is enhance the study dependability and makes the randomization procedure equitable. Blinding. So while blinding actually there is a keep secret from the participants, means participant will not aware or know about the expectation of the treatments. So the first, blinding of participants. Participants were aware of whether they were on the wait list, control group, or received the interventions. So as a result, participant blinding was not accomplished. So the evidence is the AWO50 programs. These programs scientifically improve self-reported vigorous PA and show a trend for participants to achieve the upper limit of the WHO guideline when device measured. So what is the impact of the bias? The first point is could lead to a rise in the performance bias. Second, because they are aware that they are receiving the intervention, participants may alter their behavior. And then for the impact of the self-belief, they decrease the degree of the confidence in the outcomes. For the B, blinding the therapists. The individual in each group were known to the researchers administrating the intervention. What is the impact of the bias for this? They could result in a performance bias. Impact on the self-confidence actually will decrease the confidence in the result by a small amount. C, blinding for SSS. The activity data was gathered and analyzed for blinded research assisted prior to analysis. So what is the impact of the bias? Actually, they will lessen the bias in detections, increase the objectivity of outcome measurements, means the objective will be more clear about it. Impact of self-belief will increase of confidence. Of course, the confidence will increase in the correctness of the outcomes. Attrition and follow-up. What is the meaning of attrition? Attrition actually, there is a loss of participant study in the research. Means either the participant is withdraw from the research or do not complete the research. Okay, so for this case, only 101 of the 126 individuals finished the research, indicating a 20% dropout rate. So I get this evidence, so I put it. So this sample was estimated to provide actually is 80% power to detect 30% more intervention participant, reaching 10% step per day at follow-up compared to controls, and assuming 15 drops, 50% drop and 5% is alpha. So what is the impact of the bias? The result could be impacted by missing participations. Okay, so attrition bias may result. And then what is the impact of the self-belief? I think because of the not all the participants finish the study, confidence actually is somewhat diminished. And then we go to the analysis of intention to treat. So using an intention to treat methodology, the researchers examine the participant based on initial group assessment. So we come up with the assessment first before we put it in the research. So what is the impact of the bias? It actually is to lessen the bias caused by interactions. The second is maintain the advantages of randomizations. So impact of the self-belief. So actually it's a boost trust in the study conclusions. And then the second point is to increase the results relevance to actual clinical practice. So the conclusion that I can make is the methodology of this study actually a very high quality. There's a utilized of intention to treat, analysis, assessment blinding, allocation of concealment, and appropriate randomizations, which actually is a strong points. However, blinding of participants and the therapist was not feasible. So roughly around 20% that I said before this of participants withdraw as a result defined as actually reasonably trustworthy, yet this limitation can somewhat diminish confidence in their conclusions.
Computation for primary outcome and secondary outcome. The primary outcome was achieving 10,000 steps per day. 38% of the intervention group achieved this target compared to 30% in the control group. However, the difference was not statistically significant. The p-value is 0.44. Secondary outcome, daily step count increased by 260 steps per day, but this was not significant. P-value is 0.51. Participant achieving 150 minutes of MBBA per week also shows no significant difference. The p-value is 0.345 for 300 minutes of MBBA per week. There was a positive trend, but it was still not statistically significant. The p-value is 0.09. Only vigorous physical activity shows a statistically significant improvement with an increase of 1 hour per week. The p-value of 0.01. Statistical vs clinical significance. Statistically, only vigorous physical activity improved significantly. Clinically, increasing vigorous activity may still be beneficial because it can improve cardiovascular fitness, support weight management, and reduce chronic disease risk. Relevance to patient. This intervention is relevant for women aged 50 years and above who are at higher risk of activity-related health problems. It may help increase physical activity, improve health awareness, and promote healthy aging. In adherence, no adverse events were reported indicating the intervention was safe. Adherence was good with high participation in education sessions and goal-setting activities. Applicability to physiotherapy practice. This study involved 1 to 6 women aged 50 years and above from university and healthcare workplace in Australia. The participants are similar to many physiotherapy patients because they are older adults, have sedentary lifestyle, and need support to become more physically active. This intervention was originally conducted in a workplace setting, but it can easily be adapted to physiotherapy clinics, community rehabilitation programs, health promotion programs, and primary healthcare settings. This program is highly feasible because it only requires 1 hour education session, minimal therapist involvement, and basic educational materials. An activity tracker such as Fitbit is optional. This intervention is also relevant to Malaysia because physical inactivity is a common health issue. The program can be adapted by using Bahasa Malaysia, local physical activities, and communication platforms such as WhatsApp. Physiotherapists already have the necessary skills to deliver this intervention, including providing exercise education, setting goals, motivating patients, and monitoring physical activity. Therefore, no advanced training is required. Overall, this intervention is practical, low cost, and applicable to physiotherapy practice in Malaysia.
Clinical recommendation. So the active women over 50 intervention demonstrated a significant improvement in self-reported vigorous intensity, physical activity among women aged 50 years and above. Although the intervention did not significantly increase the proportion of participants achieved 100 steps per day, it show potential in promoting engagement in higher intensity physical activity. The intervention is particularly suitable for women over 50 who are insufficiently active. From a physiotherapy perspective, the program incorporates key behavior change strategy such as patient education, goal setting, self-monitoring, and motivational support, making it a practical approach for promoting healthy aging and long-term physical activity participants. Strong evidence. The study provides moderate to strong evidence due to its randomized control trial design, concise allocation, blinded outcome assessment, and intention to treat analysis. However, several limitations should be considered. Participants were already relatively active at baseline, which may have limited the intervention effect. Additionally, the study experienced a 20% attrition rate, and some outcomes relied on self-reported data, which may introduce reporting bias. Further studies should require large and more diverse population, examine long-term outcomes, and evaluate the effectiveness of personalized digital health intervention. The Active Women Over 50 intervention incorporates several digital health technologies, including Fitbit activity trackers, motivational emails, and online support platforms. This tool facilitate self-monitoring and promote sustained engagement in physio activity. In physiotherapy practice, digital health intervention are increasingly used to support self-management and improve adherence to exercise program. From an ethical standpoint, the study received approval from the Human Research Ethics Committee, and informed consent was obtained from all patient participants. The authors also report no conflict of interest and disclose all funding sources, ensure transparency and research integrity.